you live your life to the full, have as much fun as possible. And if you do develop arrhythmias, there is unbelievable number of treatments possible.
Hi, everyone, and welcome back to STEMPOWER, the podcast where we interview top researchers and doctors in all fields of STEM. My name is Simran.
And my name is Ria. In today's episode, Simran and I will be talking to someone who knows all things heart-related. From being awarded mentorship, investigator of the year, and global achievement awards, to being invited to speak at international heart conferences, and even being the founding member and current chair of the Canadian Heart Rhythm Society Research Committee. We are pleased to welcome the multi-award winning cardiac electrophysiologist, Dr. David Birnie.
And we'd like to thank you so much, Dr. Birnie, for joining us today on STEMPOWER. We're so thankful that you were able to sneak in some time into your busy schedule for Ria and I, as we're extremely excited to get to know you and all about your work.
Oh, you're most welcome.
Okay, so Dr. Birnie, as Ria mentioned in your brief introduction, you're a cardiac electrophysiologist, meaning that you study more of the heart's electrical system rather than its mechanical function. So can you tell us how you got into the field of cardiology? What has your career path been like? And what do you do specifically as a cardiac electrophysiologist?
Well, the first part of that story is to tell you how I got into medicine. So, I knew I wanted to be a doctor at the age of 13. It was remarkable. Anytime I broke my arm when I was 13, and I was just so thrilled that I'd broken my arm because it meant I could go to the hospital. I just loved everything about hospitals, any opportunity to go to the hospital. I loved the buzz about it, everything. So I knew from the age of 13 that I wanted to become a doctor. The choice in cardiology was a little bit of a, you're going to laugh when you hear this story, but it's the truth. So when you finish medical school in Scotland, it's a little bit like when you finish medical school in Canada. You're faced with, 4 broad career paths to start with. You can either start to train to become a family doctor, you can start to train to be a psychiatrist, you can start to train to become a physician, or you can start to train to become a surgeon. And you do that for 3 years, and then you then have to subspecialize. So I finished my medicine, and I thought, what am I going to do? And I sat down one day and I thought, I'm going to, do I like dermatology? Do I like hematology? Do I like cardiology? And I got the 20 specialties down from 20 to 5. And cardiology was one of them. And then the thing that finally sealed it for cardiology for me was there was this doctor in Scotland that I wanted to work with, who was a cardiologist. And the reason that I wanted to work with him was he was also the doctor for the Scottish Football Association, so soccer in Scotland. He was the doctor for the Scottish Football Association. And at that time, if you worked for him, you also got to work with the Scottish Football Association. So, that was the main reason for choosing cardiology, was so I could work with this man. And so it turned out really well. I also obviously like cardiology as well. And then, cardiology then subspecializes. You do general cardiology for a few years, and then it subspecializes into a number of, you can either continue to do general cardiology or you can subspecialize, either to become a plumber, which looks after the blood supply of the heart, or an electrician that looks after the electrics of the heart. So I decided to become an electrician. So we deal with the electrics of the heart. Very simply, the heart can either go too slow or too fast. If it goes too slow, you put a pacemaker in. If it goes too fast, there's lots of different treatments, including medicines, some surgical procedures called ablations, or some devices called defibrillators. So I spend my time between seeing patients whose heart rhythm goes too slow, or other patients where their heart rhythm goes too fast, or there's a third group of patients where there's nothing wrong with them and just need to be told that there's nothing wrong with their heart rhythm. So that's it in a nutshell.
Wow, that's really fascinating. I liked your analogy of the plumbers and the electricians. Some would think that like something so specialized like a heart, like how can you just break it down? But I liked how you explained that. That's pretty interesting. So like you said, your path in Scotland to become a doctor, how did that Now that now that you're in Canada, was the transfer process like simple? Were you able to pick up where you left off, or how did that go?
Yeah, no, it was fairly simple. The story was, I finished my, I did my med school in Scotland, and then I worked for 10 years. And then in Scotland, and then there was an opportunity to do some advanced training in cardiac electrophysiology, and I decided to do it in Canada because it was very easy to cross train in Canada. Came here for a year. Never thought I would stay. Went back to Scotland for 2 years, and then they offered me a job, and we decided to try it because Ottawa Heart Institute is such a remarkable place to work. It really is, and Ottawa is such a wonderful city to live in. But the medical practice is very, very similar. A lot of the Canadian way of training docs is based on the British and the Scottish system. So we're trained very, 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 very similarly. The patients are very similar. Very similar to UK patients as well. So the transition of the practice wasn't hard, and the licensing wasn't hard either. And it's a wonderful place to live and a wonderful place to work.
No, I can definitely agree. Like Simran and I are also both in Ottawa, and it's a great city, and we have so much like medical information and research that happens here. It's really remarkable. So when we were doing some background research in cardiology, we learned about arrhythmia, and we found that it is something that you, Dr. Birnie, work closely with. So can you just explain to our listeners a little bit about what arrhythmia is, and if people like us should be worried about it?
So yeah, arrhythmia, it's a very fascinating thing because it's although it sounds like it's one disease, it's actually multiple different diseases and multiple different causes. So arrhythmia can affect patients at any point in their life. There's some arrhythmias that affect children and babies and so on, and then there's other arrhythmias that affect people in the later stages of their life. So we really see a spectrum, and that's another joy of it, that we look after patients of multiple age groups. Some specialties, the plumbers, for example, they generally just look after older people because patients who get problem with their plumbing tend to have coronary artery disease, which tends to be a disease just of older people. So we see patients who've got particular forms of genetic arrhythmias, so they can present to us in childhood or their teens, and there's procedures that we can do to completely cure them. There's genetic forms of arrhythmia that is just due to some extra fibers in the heart that just need those fibers just need barbecued, and then the patients are cured. There's other types of arrhythmia that happen in later life. In particular, there's one type of arrhythmia called atrial fibrillation, which is an age-related arrhythmia. It starts to affect patients in their 40s, but then exponentially increases until patients, in patients in their 90s, about 10% of the population have atrial fibrillation. It's that common. And with the aging population, we're seeing lots and lots of it. And there's, some really very effective treatments for it as well. So we're certainly never short of patients. Then there's other arrhythmias as well. There's patients where their heart rhythm goes too slowly, and again, that's generally an age-related phenomenon. Tends to be patients in their 70s and 80s and 90s. Pacemaker technology is constantly evolving, so the field is constantly changing. And then finally, there's some type of arrhythmias that are life-threatening, and sometimes that can be extremely difficult to work out, in which patients it's life-threatening and very difficult decision-making with the patient. And again, there's specific treatments for patients with that type of arrhythmia. We implant about 300 patients, actually closer to 400 now, 400 patients a year with very sophisticated devices called implantable defibrillators. They're all subcutaneously implanted. The patients, it's incredible technology. The patients live completely normal lives essentially, but they're protected with these devices if their heart ever goes into life-threatening arrhythmia, the device shocks them. And people will be very aware of from multiple television shows, Grey's Anatomy and blah blah blah, of what it looks like to defibrillate a patient externally, with the paddles and so on. So this device is an internal device that uses very similar technology, but it's obviously much more promptly working.
Yeah, I think it's crazy that there's so many different forms of arrhythmia. I thought initially that it was just something that our older population had to worry about. But yeah, as you mentioned, that it's something that even like babies have to deal with. And I've read that the primary cause of arrhythmia is an electrolyte imbalance. Would you say that the best way to treat it for young people, instead of implanting things like pacemakers and defibrillators, would you say just replenishing their body with electrolyte-rich foods and beverages is good enough for young people specifically?
No, I would not. It depends on the arrhythmia very much. There's such a spectrum of different arrhythmias. In a few patients, actually more than a few, the arrhythmia is related to some lifestyle issues, and the advice is just to change the lifestyle. In particular, alcohol and drugs can cause arrhythmias, and oftentimes we can just say, you need to change your lifestyle, and that's the answer. Also, there's a real link that's emerging between obesity and types of arrhythmia. So again, treatment, lifestyle changes is the management. It's rare, however, that we just find a patient that it's purely due to electrolyte abnormalities. It does happen, but I would say it's a tiny percentage where it's just an electrolyte imbalance.
Yeah, because I remember reading, I think it was on WebMD or something, saying that soccer players are at a very high risk of developing arrhythmia, and that the best way that they would treat it is they just drink things like Gatorade. But yeah, as you just mentioned, that is not the best way to treat it.
Yeah, again, it depends on the arrhythmia. There are, I don't know what the specific context there was. Again, the context is important. Soccer players are at increased risk of arrhythmia, but still their overall risk is still very tiny. And I think it's important to understand the difference between absolute risk and relative risk. Relative risk, is increased in soccer players, but their absolute risk is still very tiny.
Okay, well, that's a really good point to note about like maybe younger people who have arrhythmia, or like we said, soccer players, people who are like at the peak of their athletic and physical ability. But like you mentioned earlier, Dr. Birnie, like there's some devices like pacemakers and implanted defibrillators that we've also heard that can cause, actually, as much as they can benefit patients and really save their lives, they can potentially also cause fatal infections in patients. So we heard that you had worked on a device called PADIT, which helps rate patients on their susceptibility to these kind of infections. So how do cardiologists detect these kind of infections, and what can you do about it?
Yeah, it's an excellent point, Maria. These devices are incredibly sophisticated, but they're also not perfect. We say to patients, your body's not perfect, and these devices are not perfect either. They can malfunction, the leads can fracture, and so we don't take a decision to implant something like this in a patient's body lightly. We have to think about it very carefully, and it's very much a shared decision between the patients and the physician. But oftentimes the stakes are high. The patients are at risk of sudden death in the middle of the night when they're sleeping, and then it's a relatively easy decision for the patient to make. But there are downsides for sure, the ones I mentioned, and the one that you mentioned is also important. When one of these devices gets infected, and it's about 1% of these devices get infected, it's a real mess, because the infection spreads throughout the device, including down the lead, sometimes towards the heart. Antibiotics are helpful but don't cure the infection. So generally the device has to, and everything that's inside the body has to be extracted. And the issue there is if the device has been in for a while, there's very significant scarring happens. The device gets fibrosed into the body, so it gets fibrosed in multiple places in the patient's body. So it's a very significant procedure to remove it and clear the infection. So, you know, it is about 1%. It usually is related to the actual procedure. One of the issues with these devices is that they need to be replaced every 10 years or so with a new battery, and it's the actual replacement procedure that often introduces the infection. So, you know, there's multiple research projects ongoing to try to reduce the risk of infection. We've been involved in a number of over the years. We are making progress. You know, the infection rate used to be 3%. We've now got it down to below 1%. We've got some other projects ongoing at the moment that we think we can get it down to 0.5%. Will we ever eradicate it altogether? I don't know, but we are making progress.
No, that's really good to hear. Like that much decrease in such a small amount of time, like even going from 2% to 1%, that's still saving so many lives. Now, in this, I mentioned padded, and when we were reading about your research, it came up a lot as this tool that you had worked on. So can you tell our listeners a little bit about what it is and how it can be applied to clinical practice?
Yeah, no, this is one of the ways we work in medicine, and you know, we're seeing a huge change in medicine, and it's completely appropriate. You know, I was trained in, you know, I've been a physician now for over 30 years. And, you know, 30 years ago, medicine was a very paternalistic specialty. And, you know, most patients of that generation were very happy for it to be like that. You know, they would say, you know, whatever you think, doctor, you know, I don't know, you decide for me, or you know, I'm happy with whatever you think. And that, you know, there are still some patients who you know, generational thing, who trust their doctor so much and just don't want to be involved in the details of their healthcare. But, you know, there's a huge evolution towards younger patients like you folks who, you know, of course they want to be involved in their healthcare, and I want to be involved in my healthcare, and I want to be involved in the decisions about my health. And the second part of that story is that, you know, many decisions about healthcare choices are not black and white. You know, there's not a clear right way of doing things or a clear wrong way. And, you know, patient preferences are very, very important in making decisions. So, you know, but part of the third part of this very long story is sometimes it's very hard to explain to a patient the pros and cons. They don't have our training. We also don't, all of us don't have training in how to explain things in lay terms. You know, it's not always easy concepts to break into lay terms. So the final part of this is that, you know, what we've done is tried to create this tool that can make it extremely easy for physicians to explain things to their patients, and also extremely easy to the patients to understand it. So basically what this tool is, it's actually not a tool, it's a web-based thing. Anybody can go onto the web and access it. Basically what you do is you plug in different aspects of the patient's clinical features, and it basically spits out you know, different aspects get different numbers of points. It then creates the score, and the final score then tells you, it spits out basically a patient with these characteristics undergoing surgery for a new pacemaker has a risk of infection of 3% or of 2% or of 9%. And you spit that out to the patient, and the patient then can sort of say, well, gosh, 9%, I really don't fancy a 9% risk of infection. I hate infections. Or, you know, the risk is 0.01%. Well, that sounds reasonable. I accept that. So that's really what's behind it. You know, that it's the same sort of, it's not rocket science. It's part of my research. It's you know, the way medicine is going is that we're going to do more of these, make things simpler for patients to be involved in decision making.
Yeah, I think it's great that you and your team were able to create this. I think it was a score that I read online, and that you're making it so much more transparent for patients to actually know what's going on with them. And I think that's just incredible. Now, on a bit of a side note, Ria and I read that you have worked with the Medical Advisory Committee of the Canadian Soccer Association. Can you talk about what it was like incorporating your work in the lab with the players on the field?
Yeah, I know that this came from my involvement all those years ago in the Scottish Football Association. So when I immigrated to Canada, people found out that had done this type of work before, so I got involved. So it's a ton of fun. It really is. I actually am not involved. I'm primarily on an advisory basis. I don't often interact with the players one-on-one, but my role has been to really, the big concern with these elite soccer players is obviously, there is these awful stories, and it always attracts a huge amount of media attention when a high profile athlete dies on court, or there's been some very famous incidents where basketball players have died suddenly. There's also been some very famous incidences of soccer players dying suddenly in the middle of a game. So there's always that risk there. So my role has been, twofold. Number one is to help with the screening of the players to make sure that they don't have an increased risk of this happening. But the other thing, and we've advocated very heavily for, is the screening doesn't work very well. It really doesn't. A lot of these players who do have these events have already been screened, and nothing high risk was picked up. They just had these events that that were beyond the edge of medical science to pick up, and that's unfortunately that. So better than the screening has been to how to respond to it. So we've very much advocated that the screening doesn't work very well. So what has to work well is the response to these events. So we've advocated, for example, for wide access to AEDs, ambulatory, these defibrillators, community defibrillators. We've very strongly advocated. We've been involved at the Heart Institute, for example. A few years ago, we had a big rash of old-timer hockey players dying on the hockey rinks, and we said, well, this is ridiculous. What you need to do is every hockey rink in Canada should have a defibrillator in it. It's not rocket science, but it didn't exist before. Now every hockey rink has got a defibrillator in there. We're trying to do the same with soccer fields. The problem is the soccer fields are so widely spread in the city, and who maintains them, and so on and so forth. From a Canadian Soccer Association perspective, quite early on, I said to them, every time a Canadian soccer team is practicing, there should be a defibrillator at the side of the field. Now what happens is that we have some defibrillators that the teams take with them, so they're always traveling with a defibrillator. They've never ever has a team used one, but that doesn't matter. The point is that they have them there. So that's the type of work that I've been doing with the Canadian Soccer Association.
Wow, that's really important. Like I play soccer too, and I'm sure you must have some background in the sport as well. When I play, you go out on the field, and especially when it's a hot day and it's outside, and people do, if they eat, or if it's a long tournament, people do get sick, or they get heartburn, or they get heat stroke. And especially these heart conditions can be really impacting because you're running for so long. It's the stress of everything, especially for those elite players who are playing, training 7 days a week, several hours a day. So I can really see how that's important. And just, I guess, as a point of, I know you're advocating for defibrillators at soccer fields, and I see your point, it's an outdoor field, it rains, where do you put the defibrillator? It's a lot of, I guess it's a technical challenge, but what I've seen is that in schools, like Simran and I, in grade 9 in high school, I think all OCDSB schools require you to, as part of your gym class, learn how to use a defibrillator, and you learn how to use, learn how to do basic first aid for someone who is not breathing or their heart isn't beating. And I think that's really important to educate youth and educate players who might end up in these positions. And like you said, thankfully no one's had to use them, but you never know, and you always want to be prepared. So that's really important work. Now, I know I didn't mention it earlier, but Dr. Birnie, you are a professor at the University of Ottawa. So one of our listeners was wondering, what is the biggest mistake you have seen a young researcher make, whether it be like their mindset or an approach they've taken, and how can future researchers prevent making it?
Yeah, what's the biggest mistake? I see young folks doing two things, actually. The first thing that they do is in their enthusiasm, they mix up the hammer with the nail. So to explain that the analogy a little bit more, they look at a tool or a technique and try to see how many nails they can hammer in with that technique. Whereas for me, that's completely back the wrong way around. I always try and teach people that, the way to do clinical research is always start with what the question is. What's the clinical problem? Can we reduce infections in patients with devices? Can we, I can give you multiple examples. Always start with the clinical question. Can we reduce the number of patients who are dying on the soccer field? Can we reduce the number of elderly patients who are dropping dead? All of these, and then think of the clinical question first, and then work backwards to the hammer that's going to solve the problem. So that's the first problem I see, is that is sometimes the first way around is much easier to start off with. The other problem I see for young folks is that they generally try to do too many things at once. Instead of they take on 7 projects and don't do any of them well. You're much better to take on 2 or 3 and do them extremely well. It takes the same amount of effort sometimes to do a project badly as it is to do a project well. So I'm very, very, when I mentor young folks, I always make those 2 points. The third thing is always to get a good mentor.
I think that everything that you were saying is very valid, because I do some lab research as well, not with cardiology, but with Parkinson's disease. And there are some other young people in the lab, and I have noticed them taking on like 12, 13 new projects every single day. And it's just like, wow, what about your other projects? The biggest problem, well, I guess milestone really that I was able to pass was to stop getting so frustrated when my experiment wouldn't go as I wanted it to go. Over time, I just realized that when you reach the goal, it just feels so much better. And I just learned to get past that and realize that it's just a part of the process. Now, unfortunately, we're slowly reaching the end of this episode of STEMPOWER, but I have one more question for Dr. Birnie that I'm pretty sure everyone must be asking themselves. Dr. Birnie, what can we do as young people to limit the risk of developing heart problems in our later years?
Yeah, I've used the term rocket science before. It's not rocket. It's just leading a good, clean, healthy life. Alcohol in moderation, no other drugs at all, no smoking, exercise regularly, and keep as close to normal body weight as you possibly can, and don't worry about it. You live your life to the full, have as much fun as possible, and if you do develop arrhythmias, there is unbelievable number of treatments possible.
Well, I think that's some great advice that our listeners will definitely be taking to heart. And once again, thank you so much, Dr. Birnie, for joining us and sharing about your work with Simran and I, as well as our listeners.
Yeah, good luck to you all.
Thank you. Yeah, and lastly, just thank you everyone for tuning into this week's episode of STEMPOWER with cardiac electrophysiologist Dr. David Birnie from the Ottawa Heart Institute. Be sure to check us out on all social media platforms at STEMPOWER Ottawa, and we hope you have a great rest of your day.